Welcome to the deep dive. Okay, so you've definitely heard the word cholesterol thrown around,
Oh, absolutely. It's everywhere.
and probably the whole good versus bad cholesterol thing. But, like, what if that story, the one we all kind of know, what if it isn't the whole picture?
Hmm.
What if the reality of, your heart health is actually way more nuanced, maybe even a bit surprising?
That's exactly it.
So today, we're really diving deep into this condition called dyslipidemia.
Right.
Our mission. We want to unpack what this often silent condition really is, what causes it, some hidden stuff there maybe. How do we even find out we have it?
Crucial questions.
And really importantly, how the ways we manage it now are, well, kind of reshaping long-term health. We might challenge some old ideas. This isn't just about numbers on a lab report, you know?
Not at all. It's about understanding something pretty significant for your well-being, even if you don't feel it.
Perfectly put. Because dyslipidemia, it's not just high cholesterol, is it? It's more complicated than that.
Exactly. It's fundamentally an imbalance. An imbalance in your plasma cholesterol or triglycerides or maybe your levels of HDLC, that's a high-density lipoprotein cholesterol, are low.
Okay.
And this imbalance, this is the key part, it speeds up atherosclerosis.
Ah, the hardening of the arteries we hear about.
Precisely. That narrowing and hardening, which down the line can lead to what we call atherosclerotic cardiovascular disease, or ASCVD, heart attacks, strokes, that kind of thing.
Right.
And here's maybe the first interesting point. There isn't one single normal number for everyone. Dyslipidemia is really defined by the levels where we have solid proof, scientific evidence that treating it actually lowers your cardiovascular risk.
Okay, let's unpack this. So it's not just hitting a magic number. It's more about like levels where we know treatment helps based on risk.
You got it. It's dynamic based on the evidence for benefit.
That's a really important shift in thinking. So you mentioned the key players, cholesterol, triglycerides, HDLC. Can you sort of introduce the cast?
Sure thing. Well, the one that gets the most attention, and honestly for good reason, is LDLC, low-density lipoprotein cholesterol.
The bad one.
That's the label, yeah.
Okay.
And the science is, well, it's incredibly strong. Lowering high LDLC levels, huge cardiovascular benefit, no question there.
Okay.
Then you have triglycerides, TGs, another type of fat in your blood. Now, managing high triglycerides is definitely important, especially if they're really high. But the evidence for lowering them specifically to cut cardiovascular risk, it's not quite as rock solid as it is for LDLC. Still important, but maybe a different level of certainty.
Gotcha. And then the one we always thought was the hero, HDLC, the good cholesterol. For ages, it was higher is better. Simple as that. Is it still that simple?
See, this is where the story takes a fascinating, maybe even counterintuitive turn.
Okay.
So, yes, generally, lower HDLC levels do tend to predict higher cardiovascular risk. That part holds true. But what we're understanding now is that the increased risk might not be directly caused by the low HDL itself.
Yeah.
Often, it seems like low HDL is more of a marker, maybe a symptom, of other metabolic things going on.
Like what sort of things?
Like high triglycerides or insulin resistance, things like that, often travel together. And here's the real twist. Some newer evidence actually points towards a kind of U-shaped curve with HDLC.
U-shaped, meaning?
Meaning that, yeah, very low levels aren't great, we know that. But surprisingly, very high levels might also be linked to increased risk in some studies.
Wow. Seriously. So it's not just more is always better anymore.
Not quite. It's definitely more complex than we used to think. The picture's getting clearer, but it's nuanced.
That completely changes how you look at that HDL number then. It's not just about cranking it up as high as possible. So with all these players acting in complex ways, what actually causes these imbalances? Is it our genes or our lifestyle? Or both?
It's very often a mix, a real interplay between the two.
Yeah.
We generally split the causes into two main buckets,
Yeah.
primary and secondary.
Okay.
Primary causes are genetic. Basically, you inherit specific gene mutations that mess with how your body handles lipids.
How so?
Well, these mutations might make your body produce too many triglycerides or too much LDL, or maybe it can't clear them out efficiently. Or it could affect how HDL is made or removed.
Any common examples?
Yeah, a really significant one is familial hypercholesterolemia, FH for short. It's a genetic condition where the body just really struggles to get LDL out of the blood. And it's, well, It's surprisingly common. About 1 in 200 people might carry one copy of the faulty gene.
1 in 200. That's way more common than I would have guessed.
It really is.
So, okay, that's the genetic side. What about the secondary causes, the lifestyle and environmental factors?
Right. So in many developed countries, the biggest secondary factor, hands down, is leading a sedentary life combined with eating too many calories overall, especially too much saturated fat, and importantly, trans fats.
Trans fats, right. Those are really bad news.
Oh, absolutely. They're at least as bad for your arteries as saturated fats, maybe even worse. And this whole lifestyle piece, it really makes you think, doesn't it? How much is our genetics and how much is just, our environment and the choices we make day to day?
It's a huge question.
And another major secondary cause is diabetes, particularly type 2. Diabetes often creates this really nasty lipid mix. High triglycerides, lots of those small, dense LDL particles which are extra harmful, and low HDL.
A triple threat, almost.
Pretty much.
Yeah.
And then you've got other conditions too, like chronic kidney disease, hypothyroidism, an underactive thyroid, drinking too much alcohol. Even certain medications can play a role. Some diuretics, some beta blockers, even certain oral estrogens can have mixed effects on lipids.
So it's really interconnected with our broader health picture. Okay, now the tricky part. If this is all happening silently inside our arteries, building up risk without us feeling it, how on earth do we know if we have it? Are there any clues?
That's the million-dollar question, isn't it? And you're right. For most people, dyslipidemia is completely silent. You just don't feel high cholesterol.
Which is why screening is so important, I guess.
Exactly. It's crucial. However, in cases where triglyceride levels get extremely high, like really sky high, some vague symptoms can sometimes show up.
Like what?
Things like pins and needles or tingling sensations, maybe some shortness of breath that you can't explain, or even feeling a bit confused. But these are nonspecific.
Right. It could be lots of things, but sometimes the body gives us more obvious, like visible signs, especially if it's severe or genetic. These xanthomas you hear about?
Precisely. And connecting this back, these visible signs are often really strong clues that there's a primary lipid disorder, probably genetic, going on, especially if they show up early in life.
What do they look like?
Well, with really high LDL-C, you might see tendinous xanthomas. These are like firm, fatty lumps in tendons, often the Achilles tendon, or around elbows and knees. You can also get planar or tuberous xanthoma, sort of yellowish flat patches or firm bumps, awfully over joints. Then there's arcus corneae, that's a whitish ring around the colored part of the eye, the iris.
Seen that in older people sometimes?
Right. It can happen with age, but seeing it early is a flag.
Yeah.
And xanthelasma, those yellowish plaques you sometimes see on eyelids. And with super high triglycerides, like over 2,000 milli-GDL, you might get eruptive xanthomas, little red-yellow bumps that can pop up pretty quickly, maybe on the back or limbs. And in really extreme cases, an eye doctor might see leukemia retinalis. The blood vessels in the back of the eye look creamy white instead of red.
Wow. Those are definitely signals you wouldn't ignore.
Absolutely. They're like billboards saying, look deeper.
So if we're not lucky enough or unlucky enough, I guess, to have those signs, how do doctors actually diagnose this for most of us?
It usually comes down to a simple blood test, the serum lipid profile. It's often part of routine checkups.
What does that measure?
It directly measures your total cholesterol, your triglycerides, and your HDL-C. Then from those numbers, your LDL-C and another one called VLDL-C can usually be calculated.
Okay. And didn't you used to have to fast for that? I remember that being a pain.
You did. That was the standard for a long time. But here's another bit of good news. The guidelines have mostly shifted.
Oh.
Yeah, a lot of experts now recommend non-fasting tests for most people initially. It's just easier, more convenient. People are more likely to actually get it done.
That makes so much sense.
Right. You generally only need to do a follow-up fasting test if that first non-fasting test shows really high triglycerides, maybe over 400 milli-GDL or so.
That is a game changer for many people. Less hassle. So that's the standard test. Are there, like, fancier tests for digging deeper sometimes?
Yes, definitely. In certain situations, especially if someone seems high risk, despite maybe okay LDL numbers, or if there's a strong family history, we might look at other things, like measuring LPA, often called Lp(a). It's a specific type of cholesterol particle that's largely genetic and quite sticky, increases risk. Or we might measure apolipoprotein B, or ApoB.
ApoB. What's that?
Think of ApoB as basically counting the number of potentially harmful lipoprotein particles, including LDL. Some argue it's actually a better predictor of risk than just the calculated LDL-C, which is more like the total weight of cholesterol in those particles.
Interesting. So it gives a different angle on the risk.
Exactly. More precise in some cases, especially useful if triglycerides are high or someone has metabolic syndrome or diabetes.
So with all this testing, when should people actually start getting screened? How early?
Well, for kids, if there's a strong family history of early heart disease or known FH, screening can start really young, like age 2.
Wow, that early.
Yeah, to catch those genetic cases.
Yeah.
Otherwise, for most kids, the general advice is a screen once before puberty, say between 9 and 11, and then maybe again later in adolescence, like 17 to 21.
And for adults?
For adults, screening generally starts around age 20, and then typically every 5 years after that. And you continue checking even into your 80s, particularly if someone already has ASCVD or other risk factors keep popping up.
Right, it's an ongoing thing. So let's say the screening happens, dyslipidemia is found. What's the goal of treatment then? Just getting the numbers down?
The numbers are part of it, sure, but the real goal, the overarching aim, is preventing that atherosclerotic cardiovascular disease we talked about, ASCVD.
Preventing heart attacks and strokes.
Exactly. And that applies whether someone already has ASCVD, that's called secondary prevention, or if they don't have it yet, but are at high enough risk that we want to prevent it from developing in the first place. That's primary prevention.
Okay. And I'm guessing before jumping to pills, the first step is always lifestyle changes.
Absolutely. Non-negotiable foundation. These aren't just, nice little extras. They are critical first steps and need to continue even if medication starts.
What kind of changes are we talking about?
Big ones are usually diet, really cutting back on saturated fats and especially trans fats, and boosting soluble fiber. Think oats, beans, apples, that kind of stuff.
Okay.
Then exercise. Super important. The aim is usually around 150 minutes of moderate activity, like brisk walking, or 75 minutes of vigorous activity, like jogging, each week. Plus, adding some strength training is really beneficial, too.
Right.
And, of course, managing weight if needed, and definitely stopping smoking if you smoke. Smoking is just terrible for cardiovascular health overall.
Huge impact. Okay, so lifestyle is the base. Then if that's not enough, or the risk is very high, we move to medications. And it feels like statins are just
Good.
King here, right?
They really are the cornerstone, especially for lowering LDL-C. The evidence showing they reduce cardiovascular events, heart attacks, strokes, need for procedures, it's just overwhelming. Massive impact.
How do they actually work?
They have a neat two-pronged attack, basically. First, they block a key enzyme in the liver that's needed to make cholesterol. So left cholesterol gets produced internally. Second, and this is really important, they cause the liver cells to put out more LDL receptors on their surface. Think of these receptors like little catcher's mitts for LDL cholesterol circulating in the blood. More mitts mean more LDL gets pulled out of circulation.
Ah, so it lowers production and increases clearance.
Exactly. Very effective combo.
And I hear a lot about not just taking a statin, but sometimes needing high-intensity statins. What's that about?
Right. So for people at the highest risk, like those who've already had a heart attack or stroke, that's ASCVD, or people with super high LDL from the get-go, like 190 milli-GDL or more, or certain combinations of age, diabetes, and risk factors, the standard approach now is high-intensity statin therapy.
And high-intensity means?
It means using a dose of a potent statin that's proven to lower LDL-C by 50% or more on average. It's about getting a really substantial reduction.
So it's about the degree of lowering for these high-risk folks.
Precisely. Yeah. And this reflects a big shift in thinking over the years. We used to aim for certain target numbers, but now, especially for secondary prevention, it's often about achieving a large percentage reduction. And we've learned from huge clinical trials that pushing LDL-C down really low, even below 55 milli-GDL, keeps providing more benefit in reducing events.
Below 55, that sounds incredibly low compared to what maybe people thought was normal years ago. Is that safe?
That's the crucial question. And the reassuring answer from multiple large long-term studies is yes, it appears to be remarkably safe. There's just no good evidence suggesting that achieving these very low LDL levels causes harm.
That's amazing.
It really is. So for the highest risk ASCVD patients, maybe someone who just had a heart attack or has blockages in multiple arteries, the suggested goal now is often less than 55 milli-GDL. For other ASCVD patients, maybe less than 70 milli-GDL. The point is, lower has consistently proven better and safe in these high-risk settings.
That's a huge takeaway. Pushing LDL way down is effective and safe for those who need it most. But What about people who just can't handle statins? You hear about muscle aches and other side effects.
Yeah, statin intolerance is a real thing. It might affect, maybe up to 10% of people who try them. Muscle symptoms are the most common complaint. It's a genuine issue we have to manage.
So what do you do then?
Well, it's not usually an all or nothing thing. First, we might try a different statin because sometimes people tolerate one better than another. Or we might try a lower dose or even taking it every other day. The goal is always to find the maximally tolerated regimen, get as much benefit as possible without unacceptable side effects.
And if even that doesn't work or isn't enough?
Then we move towards adding other non-statin medications or using them instead if statins are completely off the table. It becomes about combination therapy.
Right, using more tools from the toolbox. What else is in there besides statins?
We've got some good options now. Ezetimibe is a pill that works differently. It blocks cholesterol absorption from your gut. Adding it to a statin can lower LDL by another 15–20% or so. It's often the next step.
Okay.
Then there are the PCSK9 inhibitors. These are powerful injectable drugs.
Injectable?
Yeah, usually taken every 2 weeks or once a month. They work by basically keeping those LDL receptors, the catcher's mitts, active for longer on the liver cells. The result is a really dramatic drop in LDL, often 40–70% lower. And importantly, they've also been proven to reduce heart attacks and strokes.
Wow, 40–70% is huge.
It is. They're very effective, usually reserved for very high-risk patients not reaching goals on pills or those who truly can't tolerate statins.
Any others?
There's also bempedoic acid. It's another pill that lowers cholesterol production in the liver, but through a different pathway than statins. It offers a more modest LDL reduction, but it can be particularly useful for people who have statin-related muscle side effects, as it tends not to cause those.
Good to have options.
Definitely. And then for folks whose main issue is very high triglycerides, especially if they're high enough to risk pancreatitis, we use medications like fibrates or prescription-strength omega-3 fatty acids.
So it really is a personalized approach, mixing and matching based on the specific lipid problem and the patient's tolerance.
Exactly right. Tailored therapy.
Are there special considerations for, say, older adults or people with kidney disease?
Yes. For older adults, say over 75, the evidence suggests that LDL-lowering therapy can still be beneficial, even for primary prevention, if they're otherwise healthy. But, shared decision-making is really key there, considering other health issues, potential drug interactions, life expectancy. It's a conversation.
Makes sense.
And for patients with chronic kidney disease, the general approach is similar. We use statins, maybe need to adjust doses for some.
Yeah.
And importantly, PCSK9 inhibitors have been shown to work well and be safe in kidney disease patients too, which is great news.
And what about pregnancy? That seems like a critical time.
Absolutely critical. Generally, statins are not recommended during pregnancy or while breastfeeding due to potential risks to the baby, though research is ongoing.
So stopping them is usually the advice.
Typically, yes, or not starting them. It's a really vital discussion to have with a doctor if someone with dyslipidemia is planning pregnancy or becomes pregnant. Managing lipids during that time needs very careful, specific consideration.
Understood. Wow, this has been incredibly informative. We've really gone deep into dyslipidemia, realizing it's often silent, the whole HDL story being more complex than we thought.
Right, that U-shaped curve idea.
Yeah, and the visible clues like xanthomas, the shift to non-fasting tests sometimes.
Makes screening easier.
Definitely. And then the treatment lifestyle first, but then these powerful medications, especially the statins and now PCSK9 inhibitors, aiming for really low LDL levels in high-risk people, and knowing that seems to be safe.
It's a multi-layered approach, absolutely. And understanding your own lipid profile, it's not just noise on a lab report. It's a really concrete step you can take to get a handle on your cardiovascular health. It's this dynamic picture, right?
Yeah.
Influenced by your genes, sure, but also lifestyle, other health stuff.
It really puts it into perspective, which kind of leads us to a final thought for everyone listening to maybe chew on.
Yeah, something to ponder, perhaps. Given that dyslipidemia usually doesn't shout its presence with symptoms, and knowing that even normal lipid levels might still carry some risk for some people, how should that change how we think about routine checkups?
Yeah.
About being proactive with screening and maybe intervention? Should we be thinking about this more, even when we feel perfectly healthy? Does it encourage a more vigilant stance towards our long-term health?
That's a really powerful question. Definitely food for thought. It suggests maybe we need to be more proactive than reactive.
Potentially, yes. It shifts the focus towards prevention.
Well, thank you so much for guiding us through this deep dive. It's been fascinating.
My pleasure.
And thank you all for listening. We hope you feel more informed, maybe more empowered about this topic. Definitely stay curious. Keep asking questions about your health. And we'll catch you on the next deep dive.